Morning. Dominique Forrest Jordan.
Here. Good morning.
Good morning. Serena Galuche.
Good morning.
Morning. Sarah Gillard. Anna Hartu. Jacqueline Jones.
Good morning. I'm here.
Morning. Akutia Khan. Garrett Leonard. Molly Martin. Beth Myers. Katie Ramos. Tara Reed. Amy Rouge. David Sampianza. Bergen Stark. Wayne Swanson. Adrian Tiller. Adrian, I see you there. Okay. Angela Tokovic. Lashita Turner. Is there anybody's name I did not call? No? Okay. All right. So next, for our group announcement, hey Michelle, can you hear me?
Yep.
Okay, cool. Just making sure. Real quick. Just wanted to make sure. Oh. Okay, good morning, everybody. So just wanted to give you one update about 6228 section 14. And that is legislation that is going to make it where SUDP licensures are going to be $100 now. And I thought it'd be a nice update to give everybody. Starting in July, the DOH is going to start doing some education, some stuff to make sure everybody knows about it. But I just thought you guys should know about it. And that's 6228. And then next on the agenda, we are saying goodbye to Teresa Atkinson. Teresa, it's been great working with you. We've been having a blast with you. I believe your last day is actually this. Is it this Friday? Is your last day? Okay. I believe it's this Friday. And then I wanted to share the SharePoint webpage with everybody, just so you know what it looks like. It's like this, and then we have the mural right here, mural that we're able to click on, and it takes us to our mural that we were working on last time when we were all together. And so I wanted to start off where we were at from last time, and just start from there. And what we did was we were just gonna we pick one of the yellow stickies and then we move it. Um, we would move it from ongoing information communication issue or ongoing policy rules requirement issue. And so we pick a yellow sticky, and then I hear from anybody that, I think where it goes, but then you guys will tell me whether or not it goes somewhere else. So I think I'm going to do the first one is probably this one: recommend expansion of specific services that can be providing prior to the completion of the assessment. I'm not moving this on to ongoing information communication issue. I'm just putting it where I think it might need to go, which I'm just moving it over. Um, so I was gonna move this over most likely to ongoing policy rule requirement issue. Expansion of specific services that can be provided prior to the completion of the assessment. Does anybody have anything to say on that right now? If they think it should go to the above one?
No, I think it makes sense in the policy rule requirements issue. But Kelly, if you could just minimize how much the screen is moving around, I think that might
Yeah,
be
I can do.
helpful. Yeah, sorry.
No, I can do that.
Making me dizzy.
We-
Yeah, yeah, I think that makes sense there. But if anyone thinks it belongs in communication, yeah, please speak up.
Okay, and if you guys don't remember, we were using the green to kind of talk about what's the barriers on this. So, for example, when people need medical inpatient treatment, lack of staffing, medical to BH crosswalk information, the biggest problem. We marked them all out. So, want to hear from the group on this. What do you think might be the biggest barrier to recommending expansion of specific services that can be provided prior to the completion of the assessment? I'm not trying to put anybody on the spot. That's the way I'm going forward. Why we think. Oh, go ahead, Amy.
I just had a question because I know there were people previously on this call who had a very good handle policy-wise on or what could and is allowed before the completion of the assessment. So if there's anyone on the call who is aware of what is allowed before assessment, I know peers, I believe, are allowed before assessment. Case managers are allowed before assessment. My understanding is counselors, in order to receive a counseling appointment, they are supposed to have their assessment done before that. But I'm just wondering if there's anyone else on the call who can kind of restate some of those from previous.
Thank you, Amy. Yeah, I know Eliza is out today. Teresa, do you think you could speak on this at all? I don't. I don't know if she can hear me. Um, so, Amy, the answer to your question, I don't think I have someone right this second that can answer that question. Um, we could just move on to another yellow sticky note for right now and come back to this to talk about barriers. And I can just leave this blank, and that will tell us to come back to it. I'm going to try to minimize moving as much as I can with the screen. So I'm just going to move like this and then move plus. So redefine recovery support services to include harm reduction. Um, You know, is this ongoing information or ongoing policy rule? I'm not so sure on that. If I can hear from someone from the group that might want to say where they think this might go, either in the ongoing information or the ongoing policy, that'd be great. It's this one right here.
I think this is Michelle. It seems to make sense in the policy rule requirement, assuming that the recovery support services are defined somewhere in policy that does not currently include harm reduction services. So to me, it seems like the next step would be like where is it defined? And then we could easily create a recommendation to adjust the definition to be inclusive of harm reduction services. But I'm not sure, and hopefully someone else on the call knows a bit more about, of that, like the if it's really just as simple as changing a definition somewhere, or if there's a series of policies that would need to be shifted to make that change. We're in your team's messages now.
Oh, thank you, Michelle.
Yeah.
Thank you. I didn't even think about
yeah,
that when I'm looking at the screen.
Yeah, so I don't know if anyone knows where the current definition is, I guess, if there is one, or yeah, again, if this is more like we'll just need to find the different places that recovery support services are mentioned, and start to include harm reduction services. Anyway, I guess what I'm saying is that's where I think it belongs, but I'm not sure what the specific barriers might be to it. But Teresa's got her hand up, so.
Oh, got 3 people. Okay, go ahead, Teresa.
Yeah.
Yeah, just I don't know about the whole term recovery support services, but I'm pretty sure the state of Washington usually uses the SAMHSA definition of recovery, and I can put a link to that in the chat. It's a very holistic definition of what recovery means, and it's not specific to SUD, it's not specific to mental health, and it talks about like a whole person returning to a place of healing and like self-efficacy. So I'll put that in the chat. But sorry, I got pulled into another call, so I hope I'm not speaking out of turn.
Oh no, that was good, Teresa. Thank you so much. Sarah?
Yeah, I think so yeah, the SAMHSA definition of recovery is, I think, what Teresa was speaking to it, but also I think the bucket of recovery support services might mean something more specific in the SERI like billing guide, for example. Like I think there are some services kind of bucketed under that are like reimbursable by Medicaid, for example, and different funding streams. So I don't know. I think maybe important to think about redefining for the purposes of managing like stigma or public perception, or redefining for the purposes of potentially advocating for policy change, difference in reimbursement mechanisms, things like that. Because I believe, and I don't know, it sounded like maybe Eliza wasn't on today, who's sort of the go-to for the Medicaid billing and stuff, or maybe Gail has an idea. But I wonder if we need to kind of define, I guess, why we want to redefine recovery support services for the purpose of this group.
Okay, thanks, Sarah. Beth, you had your hand up?
Yeah, I just was, I went to the Change Companies had a training recently on the ASAM, the new ASAM, and I thought it was incredibly enlightening. And there's a lot of changes happening with that are going to address a lot of this harm reduction it's not, the terminology isn't specific to harm reduction, but what I was recognizing when I was reading these new guidelines for the ASAM, dimensions, is that there's going to be two assessments. There's an intake assessment, and then there's the long-term assessment. Forgive me for not recalling the exact terminology at the moment, but yeah, I just wanted to throw that out there because I think we were all talking about one assessment for a long time, but now there's going to be two assessments. There's going to be the assessment for intake into a program, and then there's going to be the assessment for long-term treatment goals. So I don't know if that has anything to do with this. I think it's just the language, harm reduction services. I think redefine recovery support services to include harm reduction. I think everything we're doing is leaning towards reducing harm for people. I mean, that's why I'm here. So I don't know if the language is what they're talking about, where redefining recovery support services to include harm reduction services. A lot of that's going on all over the state right now, all over the world. Anyway, that's all I had.
All right.
Thanks.
Thank you, Beth. Appreciate that. Okay. Shortening the process to get into desired services, limited options available to offer people coming from the ER. Ongoing information or communication issue, or ongoing policy rule requirement. I almost feel like this one is sort of like in between both of them. So, because it can really go on either or. Michelle, I just saw
Oh,
you
sorry,
light up
I
for a second.
hiccuped.
Sorry.
That
Sorry
must have
about
been
that.
what, yeah, sorry.
Shorten the process to get into desired services, limited options available to offer people coming via the ER. This could be an ongoing information communication issue because sometimes, like with no wrong door, some of the inpatients don't feel, even though they could take someone from the ER, they might not feel comfortable because they need more education around the billing aspect of things. They don't need that assessment necessarily. They might need some information, but not the whole thing. Then again, there might be some ongoing policy or rule requirement issue that might be a problem. I'm thinking that this goes under more ongoing information and communication issue. I'm willing to see what else you guys have to say, and then I can put it in the appropriate one. Okay, I will put it in here then. This green. All right, what are some possible barriers or that we can see with um, limited options available to the offering people coming from the ER? I'll start off finding a bed. I would say a res bed if it's needed.
I mean, could this go into detox services as well, like finding
Mm-hmm.
available detox services 24/7
Mm-hmm.
with availability for ER patients or ED, whatever we want
Yeah.
there.
Yeah, because some detoxes do run 24/7. I don't really know any that do intakes in the middle of the night off the top of my head, but it'd be pretty cool if they did. If we had a detox that ran 24/7 that could take intakes at any time of the day.
I feel like that could be big for emergency rooms when they when someone comes in on a truly drug-related issue, if they could be quickly assessed and then moved to an appropriate level of care outside of the, hospital setting, which is taking a bed, to the appropriate places, and then
Mhm.
hopefully on to treatment.
Agreed.
Evergreen and Fairfax both take people 24/7.
Oh, that's good to know. Okay.
Lately,
Uh,
it could change any moment.
right. For Dominique.
Yeah, I was kind of going to piggyback on the same thing. I think it is having the services available, but also having the staff at the hospital who can create the assessments or the referrals to get the person in. Because typically what I've encountered is it's all just referral based, where the patient is expected to go out and seek detox, seek treatment without any assistance. And if they're in crisis, that's really that's an unrealistic expectation, right?
Yeah, so I understand what you're saying. So needing more staff at hospitals to get referrals in. So because there's some hospitals at at a certain time the social worker goes home.
Right.
And there's some hospitals where there's a social worker all night, but those are far in between. I think it'd be a lot better if we had more staff at hospitals that would be trained on how to get referrals in.
Or even conduct a short intake or or even a form of an assessment so that the patient can, because that's the biggest barrier is the assessment. So having someone who can do those things and be for lack of a better expression, the case management to assist the patient in getting into services could be helpful.
Yeah, when I'm thinking of that 24/7 access thing, I'm thinking more along what was just spoke about, in that it would be a start to finish thing, as in, like, I forget that people are sent out, just here's your referrals, now go make it happen. This would be like handling with care all the way through, arranging transportation, making sure that that the person gets there, so they are successfully sent to the level of care they need upon discharge from the emergency room. Transportation is a big part of that, and coordination.
It's not letting me move it. Oh, there we go. All right. Are we good to move on to the next yellow sticky? Could I see some thumbs up, or if someone has something else one of the other barriers to this, I would be more than happy to put it down. Okay, so I don't have to move the screen that much. I didn't see anybody have any issues, so I'll move on to the next one. Difficult to follow up on referrals once they are made primary to SUD. I'm going to put this on an ongoing information and communication issue. I don't know how it would fall into ongoing policy. I guess it could, but I would say it's more of that. If anybody else thinks different, just let me know and we can move it, of course.
This is Michelle. I just want to make just a quick suggestion to
Mhm.
rephrase the way it's worded into a
Yeah.
desired outcome so that it's consistent with the rest of because difficulty following up, that sounds like a like a barrier, right? So the desired outcome would be I guess something more like easy to follow up on referrals once they are made. And then what gets in the way of that, right? So if we know that it is difficult, that that's something that we want but don't have yet, then we can start to talk about barriers. But just not to be nitpicky, sorry, but just so all the yellows are desired things.
Hey, so Michelle, you said easy to follow up on referrals. Was there another part of that?
Once they are made, so basically just replacing the word difficult at the top with easy, and then
Okay.
that'll make it the desired outcome instead of the problem.
Yeah. Okay, so what is the barrier to follow-ups after someone has been made referred to somewhere? What do you guys feel like would be the barrier to that?
I can pull up the notes from that meeting that we had about the medical setting referral, because that's what we're talking about, right? Primary care to community SUD. Is that what that means?
Well, I was thinking more this could be to anything, because like for instance, if someone is if someone's referred to any kind of level of care from anywhere, how do you make the follow-up? Because like one thing I'm thinking of right now off the bat is like communication. Some people don't even have like a cell phone to communicate. So how do you get a hold of them if you need to? Oh, Dominique has her hand up.
I mean, yeah, I honestly think moving away from the idea of referral was needed, because if patients, if all, if somebody could get themselves into treatment, they wouldn't be in crisis.
Mm-hmm.
So a referral is like putting a Band-Aid on something, right? You are hoping to manage a crisis in the moment, and you refer somebody to a service, and like you were saying, they may not have a phone, they may not have an address, they may not have transportation, they may not have insurance, they may not be able to read, something as simple as they may need glasses, all of these barriers. And so when you give someone a referral to an already marginalized population, you're just giving them, they feel like a number.
No, I can
So
see.
I
I
think
see.
the key, I'm sorry,
Go ahead,
the
Dominic. I'm sorry. Go
key
ahead.
is going to be creating a system where we're not referring someone, where we have the ability to put people in places so that once they receive getting the referral or getting the assessment goes directly into, if they are in the action stage of change, to getting them in, finding them a space in the level of care that they have been qualified for. And it has to be like a seamless process ultimately for it to be successful, in my opinion.
I
I would
recently heard, sorry. Go ahead.
if somebody can follow through on a referral, they probably don't really even need a referral.
Oh
Right.
yeah, that's true. That's true, Meta. Yeah, for
If
sure.
somebody's got the agency to do that, then the referral isn't going to make a difference. And if they don't, then the referral also isn't going to make a difference. Yeah.
No, I totally agree. Yeah, when you hand someone a piece of paper and say "go here," and if that here isn't 5 feet away, it could be a long journey to get to here. So I totally agree with you on that. Thank you both. Dr. Khan?
So speaking from the primary care aspect, from the medical side, having done this for a while, I will tell you, there is so much confusion and lack of clarity. A lot of times when you talk to patients, they don't even know what counseling means. A lot of them think it's mental health counseling. They're not even aware that they are being referred to a substance use disorder counseling, number one. The other thing is, on the primary care side of things, not a lot of clinicians or physicians or providers are aware that substance use disorder counseling is also a thing. So a lot of colleagues, because we provide both services in our locations, and when I talk to people, so many providers have no idea that this is what we do. To begin with, a lot of people still think we're a pain clinic, and I'm talking, these are like people in healthcare who think we're a pain clinic. So number one, clarifying that this is not just a pain clinic service, or we're not actually a pain service. We're an addiction medicine service. And then going there from a referral to an SUD counseling, I think that's what we were talking about, right? Just to clarify.
Oh, that's part of it for sure. Yeah, you're right on. You're right on there, Dr. Khan.
Right. So I think that lack of clarity, I think, needs to be addressed, because there is so much disconnect. This entire treatment is so fragmented, and I think the patient bears the brunt of it, because the resources are so fragmented. And really nobody has a clue when the patient is being discharged, like where should these patients go. And of course the patient, because of their lack of motivation, because we always talk about these patients having this window of opportunity where they don't always want to seek treatment. There's always that little window that could, for some people, it could be a couple of hours. For some people, it could be a couple of days. And after that, they don't want to engage. So when they are ready, they just kind of go from point one to point B. And when they finally get there, there's either a wait, or the service that they were referred to the incorrect location or whatnot. So as a result, there's delay in providing services. And by the time they finally get to where they need to be, they're done.
Yeah, no, great point, Dr. Khan. I made note to some of the stuff you just were speaking about. Need more clarification, services given, more providers. I think I might put maybe clarify that more medical providers
Yeah.
need education on SUD services, SUD counseling, MOUD, OUD, etc. The different levels of care, and I think boistering to the medical staff more education. And sometimes they're craving it. Sometimes they're really wanting it, so they can give good services. Any more comments on this one right here that I can put another green sticky note for?
I would just like to say that it takes continuous, sustained effort to integrate this knowledge into. I work directly with ER and primary care and hospitalist in the ACU and ICU units, and it's a small rural hospital medical center. But everyone is very busy doing their jobs, and they don't have a lot of time to learn something new. And so I find it's important for me and the services I provide the patients that I work with, that I go and continuously speak with the providers. They forget, and they get an understanding that works at the time. And so it's a continuous effort of disseminating this harm reduction language and understanding what is available and how to access those services, which I have found it's fairly simple. It's just a matter of being consistent and knowing what is needed from the patient and the providers and the detox centers and inpatient treatment centers. So it's just communication and language barriers that that require continuous sustained effort and dissemination.
Thank you, Beth. Appreciate that.
Yeah.
Okay. I think that goes with the last one. I choose this one? Facility closing, treatment facility shortage. There's part of me that thinks it's ongoing policy, rules, requirements, issues, because it could mean more funding of some sorts. It could be ongoing information because maybe people aren't billing all the stuff they're doing or the services, or it could be, getting more information about how to get beds quicker for people who need them. I'm willing to. Oh, sorry about that. I'm willing to hear from anybody that which one it should go into.
I think that goes into ongoing information and communication because facilities open and close all the time.
Hmm.
It's just another information management issue.
Yeah.
Communication. Yeah.
One thing to consider in that as well, and sorry I didn't raise my hand. This is Sarah Melfi Klein. I think a lot of the facility closures also maybe have to do with the staffing, and not being able to staff with our behavioral health workforce shortage. So I kind of wonder, a lot of these are nuanced and kind of a hybrid and where they fall based on communication. And I agree. I mean, keeping up with the facilities that are closed versus open and what services they offer is definitely a communication issue. And I wonder if the behavioral health workforce piece, is kind of more of a policy piece. So not to add complication, but I kind of wonder if exploring the barriers from both the communication side and the policy side makes sense for some of these. So I think for that, Kelly, yeah, exactly. Read my mind.
Oh, let me change it. Okay, I'll do it later. But so lack of staffing could be an issue. What are some other issues with what are other barriers to facilities closing and treatment facility shortages and stuff and such? I mean, I'm thinking like maybe there's now a lack of service being provided due to that closure. If a detox closes, then there's a lack of service being completed. I remember in Pierce County, we have MDC in Pierce County for the detox. And I remember they closed for some time for some reason. And that's the only it's like an 18-bed detox or something. And it's the only detox in Pierce County. And when that place closed, like there was like, where are we going to send our people for detox? There is another detox in Pierce County, but it's private mixed with like a couple of the MCOs. But MDC took all the MCOs and then it went down and the lack of service was big. Dominique?
Yeah, I remember. And I think what I've encountered is that it boils down to insurance typically.
Yeah.
And that's another barrier to facilities being able to provide the services is I know oftentimes they run into, I guess, incorrect billing. Or the ability to bill the insurance. And I'm not real familiar with that aspect of it specifically.
Yeah, I think that whenever somebody closes down, if it's for an insurance reason, because I've heard rumors of that before, where facilities have said, "Oh, we weren't able to get our money back from the MCO or something like that," and that's and that's something maybe facilities would like more training from the direct MCOs or from HCA about how we can make sure billing is done correctly so that everybody's happy with the billing of it all. Um, but yeah, I think the ability to bill insurance is a definite barrier sometimes to facilities. And I've heard that from other people in other facilities before too. Any other green sticky notes for this one? Okay. So one of these I think actually goes with, and you guys correct me if I'm wrong on this. Where is it at? Oh, maybe it's not. I thought we. Okay, yeah, right here. Shortening the process to get desired services, limited options available to offer people coming via ER. I feel like this is like almost the same thing. I'm gonna make this a little bigger. It's gonna cover the other one, but options for hospital beds when not available, ER to SUD treatment. Do we feel like this is the same thing? I can just like put it right next to it, or are we feeling like this is something different from this? Okay, I got one thumbs up. Any hand raises to say maybe we should have it as separate real quick before I just leave it there? I'm not gonna delete it and I'm gonna keep it. It's just gonna go right next to it. So it's like together. All right, I'm gonna move into this investment the state is making into housing and future meetings to talk about. Um, I feel like this would go to ongoing policy rules requirement issue. Unless there's like a lot of housing not being used for some reason, and they would need like an education campaign or something like that. But if someone feels like this should go to ongoing communication issue, please raise your hand right now so I'll we can discuss it a little bit further. Housing is always a good topic. Okay, Tony.
Yeah, I agree. Housing is a really important and critical topic, and also it seems a little bit outside the scope of substance use disorder intake screening and assessment. So I don't. I'll just throw that out there for the work group, and the work group can kind of push back or um,
Yeah, I mean, and also too, guys, if we do come up with something that, for instance, like investment in the state and making into housing and future meetings to talk about, um, we can say this could be outside our scope, and we can just leave it, and we don't need to delete it. We can just leave it, and we can just wait for the end, and then we can see what we want to do with it after we get done with other yellow sticky notes. Put it off to the side. Beth?
and
Oh no, sorry. Oh. Hey, Tony, go ahead, and then I'll go back, and I'll go to you, Beth. Okay.
No, that was an accident. Thank
Oh,
you.
okay.
no, sorry. The only thing I was going to add is unless, and I don't know who's on the call, but unless there are housing admission requirements that are tied to some sort of intake and screening process that like clinical staff and frontline staff are involved in. I don't know if that's the case. And even then, I would question whether or not it's within the scope and the purview of the work group. But that might be the area where the connection is made, like what sort of screening and intake requirements are like recovery residences or housing providers requiring, and is that information coming from an SUDP or other clinical medical provider?
Thank you, Tony. Appreciate that. If everybody's okay with it, I was just gonna put this yellow sticky note to the side, and we can come back to it at the very end, and we'll put it in the corner. Beth, was that an accident again? Yeah, I think it was. She put thumbs up.
Yes, sorry.
You're not the only person who makes the accident between the raise hand and react. I've done it too. Okay. If there is not time to address it during the current visit, there can be problems/challenges with follow-up primary care to SUD. And so, you know, I'm going to read it one more time for everybody. If there is not time to address it during the current visit, there can be problems, challenges with follow-up primary care to SUD. I don't know where this would fall, if it would fall under ongoing communications or ongoing policy rule for this one, where it would land actually. If somebody wants to comment on this.
I think you can, and this is Beth, and it seems like that might have been something I was perseverating at the beginning of all this, and it probably doesn't belong anywhere. This is something I was trying to figure out. One of the issues I face is follow-up for people, and that actually not punishing people for missing appointments is a harm reduction principle, and hopefully that's going to be integrated soon with other, when the knowledge comes down and gets shared with other people. But
Beth, I did actually pair it up with this one though. I think these two go along together pretty
okay,
well, and so I'm just going to keep it and put it on. Is everybody okay with that? If I just go ahead and move them next to each other, it's pretty much the same thing. It's just written in a different way. Okay. Let's get rid of this big one. I think some clinics, especially FQHCs, will have social workers trained to take on management of behavioral health referrals, but not able to conduct ASAM assessments. General referral managers may not be as familiar with the referral to behavioral health services, BHA's primary care to SUD services, BHA facilities only. Um, not to put anybody on the spot, but Teresa, isn't this like rule changing? Isn't there something that's happening in this with some of the new stuff coming out? The waiver, I think maybe this might pertain to. I'm not 100% sure on this one.
Are you talking to me or is Teresa Claycamp on the call? Because that felt like a Teresa Claycamp question. I just want to make sure.
Oh no, I think I was. Yeah, I was talking to you, Teresa. I'm sorry. I
Okay,
think maybe
that's okay. I don't know that I can speak directly, but I don't think I have enough information to answer that question.
Okay. Yeah, I just can't remember. I feel like, but I do feel like this is an ongoing policy uh, issue. If someone feels different, we can go ahead and have a conversation, and I can move it into whichever one. How's everybody feeling about this being an ongoing policy and rule requirement box? Okay.
Yeah, I think any new licensure recommendations or requirements would go in the policy shop.
You know, and the barrier is kind of already written in there as well. I feel like, it says general referrals may not be as familiar with, or yeah, I feel like it's already written in there. I'm gonna go to my next yellow sticky note, and then I'll come back to this one. You can put down more barriers. If everybody doesn't mind reducing wait list times, I'm guessing this is probably for the ER stuff. I'm gonna put it with these other two. If anybody has any issues with that, we can make its own box. I don't know exactly how that would go with us, but I think it goes along with these other two. If everybody's cool with that. Okay. Greater accessibility availability of mobile intake to serve people who can't leave where they're living at. Um, I feel like this is probably an ongoing policy rule requirement. I'd like to hear any conversation where it would be more ongoing information and communication, because I feel like I know there's mobile intakes in Washington State. I just don't know how many there is, or maybe if we might need more. And I feel like that feels more ongoing policy. But I'm really curious to see what you guys think about this right here, if it should go to ongoing information or ongoing policy. Amy?
I feel like it's policy.
Okay. All right. I'm gonna go ahead and just move this to policy. And so what is the barriers to not having to getting up, Alicia?
I was just wondering about the comment because there's still telehealth in the state. So is this talking about like going into the jails or going into the hospitals? I'm just a little unclear as to what those specifics mobile units the comment is talking about.
Yeah, I'm pretty sure what I'm reading from it is that anybody who can't leave where they're living at. And I think they're talking about more or less like maybe people who can't leave their houses and such, because usually jails and stuff, some jails have their own programs. I know not every jail does. And then some jails are contracted with HCA and other medical clinics and stuff. So for different things. But I think this is talking about, and if somebody else wants to speak up and they want to, maybe I mean to redo the yellow sticky note, but I think it's talking about people who cannot leave their home or their an unhoused area of where they're at. Oh, Meta?
Yeah, I specifically wanted to highlight that unhoused piece. There are a lot of people who, might have mobility issues, who are living outdoors, who can't use public transportation for some reason or can't get to where they need to go. There are rural areas where people could definitely use mobile assessments. Yeah, I think that's a big bucket of people. Yeah.
All right. I don't know what I was gonna put. If someone has another way, there's a barrier for this. Okay. I'll go ahead and move on to the next yellow sticky note. Um, I'm gonna go ahead and move this right here. It's gonna overlap it a little bit, but it basically says the same thing as this one. It says definition of recovery sports services broaden and cover harm reduction, and that's
It's right here.
right there.
Somebody gave it to me. Libby did. I mean, not Libby.
Oh, hey, Amy, we can hear you.
Thank you.
No problem. We've all done it. All right. So next one. Oh, where did I put it? Okay, this one right here. I want to put it here. Diagnosis and preliminary treatment can be established before unpacking other factors. Full assessment / 90 days allowable to complete full biopsychosocial assessment instead of 14. I think that this would go to ongoing policy requirements because I think that it would have to be like almost a new law for us to be able to do something like this. This kind of has the barrier written into it as well. Because I believe how I'm reading this, if someone else reading it a little bit different, but how I'm reading this is that basically instead of saying you only got 14 days to fill out an assessment, you would get 90 days. Not saying that's what we're trying to do right there in this moment, but that's just what someone suggested as this is the barrier and this would be the solution. So if people can think of possible barriers to only having 14 days to do an assessment instead of, I think of lack of contact, how people come into services, then they leave, and you don't see them for 3 weeks. And, you know, if you couldn't get the full assessment done, are you penalized because you couldn't get the full assessment done in that one session? Dominique?
And that could also be a barrier, could also be like, again, we go back to the insurance, because how is it billed? If you let someone into treatment before they receive a full assessment,
Mm-hmm.
like what's the billing look like for that? Because I know that's part of the process for billing is the assessment as well.
Yeah, because I worked in outpatient services for years, and um, if I had someone who did an incomplete assessment and they just left, I was unable to bill it at that time. It just vanished from basically my schedule, and I just couldn't do anything about it. And
Right.
so,
It's a wasted hour and a half,
mhm,
yeah, of the
yeah.
day. Yeah.
So, um, one of the things I think this would give us, just to give y'all a little something, that's I think from a provider's perspective, is that when you give someone more time, like 90 days, I think that it becomes more person driven than billing driven, which is kind of cool. I think people are really wanting it. So, but that's just a perspective from mine. But yeah, any other barriers we think that would be for not getting a complete assessment done, I guess, or something, or 14 days?
So the ASAM is going to be recommending that there are going to be two types of assessments. The intake assessment, which is going to be short and sweet and clear, so the person can get into treatment immediately, and then there's going to be a long-term treatment planning assessment. I'm not sure about the timeline or the billing, but I imagine insurance is going to have it. It's going to be a big, long transition for insurance and policy and everything to implement these two different assessments.
Yeah, I just wonder if there could even be and I'm speaking more of a goal right now, but I'm kind of curious if there's even like a thing in the future where if someone needs services right then and there, if that small assessment, if that can't do it, if there's still a way to give more time to get the assessment completed. And I wonder how much time ACAM is recommending for people, because that's going to change things too as well. So, but yeah, ACAM could answer this problem. I will look into it. Any more barriers for this one that we want to outline? Okay. Services provided can initiate medication prior to assessment process, MAT, because sometimes medication itself is enough to stabilize the individual long enough to conduct an assessment and ensure greater chances of following through with recommended services. I would put this down with ongoing policy rules requirements, because as of right now, I believe the assessment, I don't know how much time the assessment when the SUD assessment is completed, MAT services, someone could speak on this. If someone does SUD service, like MAT services or MAUD, the assessment, you get a certain amount of time. You can start giving someone medication before the SUD assessment's done, I believe, right?
Yes. Currently it's 30 days, but we're also moving to the 14-day.
Mm.
But I know there's different things. Currently we have 30 days. After 30 days, the individual is put on a detox plan until the assessment is completed. the 14-day thing, we're dealing with how to implement that. So we have a baseline we're going with, which is 14 days, but still we'll be giving them up to 30 days before a detox. But we're changing our language and changing our directives to the clients on when they need to complete that actionable item by.
So if someone doesn't stay, like if someone doesn't complete that assessment, then you guys initiate a detox protocol?
Yes,
Okay.
until they complete it.
Okay, gotcha. That's rough.
It is rough, but we have to have an assessment at a certain
Yeah.
period. At this point, right now, under the current guidelines, we have to have an assessment, and they have 30 days to complete with us, and then they go through a detox plan. So it's not like they're kicked out of treatment by any means. But typically people complete it very quickly once they've
I
met the
wonder
days.
I wonder I wonder if the new ASAM is going to have an answer for this because they're coming up with those smaller assessments. I wonder if that level of care slash like the other part of the assessment, like I know it's going to be two different things now. I wonder if this is going to help that, because those are supposed to be a little bit quicker so that you can say, hey, this person does need the services, and you don't have to spend necessarily 2 hours with them to get all the answers right away. I wonder if this is going to be a possibility. It's something I'm going to look into. But another barrier might be the time restraints for an assessment. I'm guessing, Amy, is that what you were kind of saying? Time restraints can be a barrier.
Yeah, they're as far, do you mean time restraints of the complete assessment process or
Yeah.
time restraints? Yes, the complete assessment process is long. Would love to see that shorten up. We're currently data mapping our assessments right now to see if there's any in-house, to see if there's anywhere we can shorten them ourselves.
All right. Any more barriers that people want to speak on with this one? Okay. Wow. We only got a few more yellow boxes left and we're done. One issue with assessment is that treatment centers can sometimes not accept the assessment already conducted by another agency organization and instead to do it themselves because assessments are billable in inpatient hospitals SUD treatment. I don't know where I would exactly put this one. Because I don't know if the WAC currently says that it's against the rules or if it's for accepting someone else's assessment. I think you can accept someone's assessment. So that could be an ongoing information communication, let people know they can accept other people's assessments, or might be a WAC law that needs to be done. Oh, Dominique.
I too, I think it can go either way because I feel like for everyone to be on board, it would take a WAC, for lack of a better expression, and education on how it's helpful. Because I've been in the field for roughly 15 years, and in those 15 years, it's harder it's harder to get someone in already with an assessment because the agency, for whatever the reasons are, prefer to do the assessment themselves. And of course, not all, I've run into both.
No, I agree with you. I ran into the same thing when it comes to other agencies, and I've been with agencies that don't accept them and some that do. Teresa?
I just was going to respond to that. You know, I don't work in direct service anymore, but my experience was that if the assessment that was sent to the agency I worked for was not up to the WAC standards, then we were held accountable to that by DOH when they would come to do site visits and things like that. So the most reliable fix for that issue was that we would have to do our own assessment. Even if we accepted something from another organization and brought it into the file, it was our responsibility then to also redo the assessment anyway. So I'm not saying for or against or anything. That was the reasoning behind why we had to always do another assessment as soon as the patient arrived, regardless of having one in the file, which again is completely re-traumatizing, re-triggering. It's not a best practice to have folks have to go through that entire process multiple times just to make sure that we meet standards, but it was either that or risk getting cited. It's like, I mean, you guys know, everybody probably on this call knows that stuff.
Okay, I was able to put that into a little box there, Teresa, because that might be a way. Maybe there's something we can do with the ongoing rules and policies with that. That if someone, just an example, I'm not saying this is what's going to happen, but you know, someone accepts an assessment, maybe they're not fully held to what happens in that assessment to a certain extent. You know, I don't know what that would look like, but I think you're right though. I've been cited before when I worked at an agency because we accepted an assessment from somewhere else, and it was when the gambling questions came out, and that assessment didn't have the gambling questions and such in it, and so we were held responsible because we accepted the SUD assessment. All right. Anyone? I don't know if you guys noticed. I kind of made the green boxes between the two spots. um, but any more green notes for this one? All right, I'm gonna do one more and then just go over what's left of the agenda. Okay, so when we come back to our next meeting, we'll only have like a couple of yellow stickies, and it's gonna be goal setting time, I believe, for the next session. Um, People are getting connected with support needed in the moment, especially with outreach, difficult to follow up with people. We have one that matches that already, I believe. Or maybe I read it and I left it there. I thought we did. Okay, I guess we didn't. My bad. Being able to connect with people with support needed in the moment, especially with outreach. So these two are pretty much the same. Um, I feel like these two right here would most likely go on to. I don't know where these two would land. If I'd like to hear some input from the group maybe on where these two might land. I think the closest I can come up with is I think these are both most likely ongoing information communication issues um, with difficult to follow up with people. Um, all right, I moved them both over. I think these kind of have the barriers written in them. Honestly, these two right here. Because they're saying the barrier is being able to connect with people with supports needed in the moment. So I feel like that's like the barrier basically. But I feel like actually this could go like this, honestly. Change this to green. People are getting connected with supports needed in the moment, especially with outreach, being able to connect with people with supports needed in the moment. Oh, these are actually the same one. Oh, these are the, there's like, yeah, I'm gonna delete it, guys. Okay. All right. So any barriers to this one that people want to mention? All right. I'm going to move on to the last sticky note and just go ahead and place it so then we can at least have the sticky notes things done. And then when we come back, I think we'll just have a couple of green things to fill out and then we'll be done. Establish uniform standard of requirements. County requirements vary so much. I feel like this would go under ongoing policy and requirements. I'd like to hear from the group on anybody if they think different, if it thinks they should go somewhere else. Okay, want to go ahead and move it. All right, Michelle gave me a thumbs up. That's great. All right, I'm gonna create. Nope, I'll do that. Create a sticky note. Green. Sorry, guys. Oh, oops. Just doing this real quick, and then I'll be done. Okay. There. Okay, so we'll have 3 boxes to fill out when we come back next week. I'm just gonna go to the agenda real quick. The last things. Oh, so hey, Teresa, did you hear us say goodbye to you?
I must have been while I was on my phone call. I'm sorry, I missed that.
Yeah, you didn't respond or anything. And I was like, oh, okay, I guess she doesn't want to have a good, and say goodbye. But tomorrow is your last day, correct?
Friday, yeah. I
Or
leave a week
Friday,
from
yeah.
today to move across the country, so it's crazy.
Yep, and you're going to North Carolina, correct?
South
South. Okay,
Carolina. Yeah. I'm gonna go
Okay.
open a new inpatient program down there called Seagrove Recovery. Super excited.
Okay, that's great. Well, it's been great having you here, Teresa, on the work group. I know I talked for everybody in the group to say that we're gonna miss you and giving you a heart out there to
Thanks,
let you
guys.
know that we're here for you, and we hope great things for you in the coming future.
Yeah, it's been my privilege to get to watch the work that this group and SURSAC have done over the last few years. I think Washington is definitely a pioneer when it comes to just trying to figure out how to help people in better ways and better practices and harm reduction and all those things. Are just really great conversations, really hard work that you guys are committed to. It's beautiful.
Thank you so much, Teresa. It's been great having you. Gonna miss you, and if you need to volunteer work, you can just call. We'll work it out.
Absolutely. I'll keep an eye on what you guys are doing from afar. Thanks, everyone. Thanks, Kelly.
Thank you, Teresa. Last thing to talk about is planning next agenda. So I'm guessing my idea about the next agenda, unless somebody has something particularly they want to make sure that I get onto the agenda, is that we fill out the last little bit of the green boxes. There's only a couple left for the barriers, and then we go on to recommendation ideas, potential solutions. I might talk to Michelle and Sarah more about this a little bit, but I might ask you guys to go ahead, like I might send out an email reminding everybody, like, hey, here's what the mural looks like right now. If you have potential and idea recommendations, you can think about them and then bring them in instead of having to think about them on the spot. Because I know it's a lot that everything we just did, that's a lot to be put on the spot for. So I think maybe having the idea recommendations, maybe next meeting might be a good idea just for everybody. Is there anything that anybody wanted to add to the next agenda? I get a thumbs up for some people saying that sounds good. Oh, Michelle, you got your hand up.
Yeah, I think that's a great plan, Kelly. I just also want to throw out there that we might want to consider prioritizing or having a conversation about how to prioritize these many items based on the legislated like mandates for the group. So we've got like the things that the legislature has told us to tackle, and then we have these related but somewhat periphery desired outcomes as well. And ideally, we'll be able to get to them all and provide a really robust, comprehensive set of recommendations. But just being aware of time and priorities, just in case we don't get to it all. I'm just we may want to have a conversation about which ones we tackle, especially as we move in from the green barrier stickies into developing problem solving recommendations from each of these, within each of these clusters. So I just want to, we don't have to do anything right now around that. I just wanted to throw that out that, as we decide the order in which to tackle these, we'll probably need to prioritize the things that are most directly related to the mandates from the bill.
All right, thank you, Michelle. I made notation of that. So for the
Yeah.
steering committee, for the next time when we meet for the steering committee, we can bring that up for sure. So I notated that. All right, well, everybody, I'm going to give you back 2 minutes of your day. Appreciate everybody. I appreciate all you guys for being here today. You guys are amazing. Thank you so much. This is great work we're getting done. I remember when this mural was but just a thought. Look at that. That thing is getting built. Thank you so much, everybody. Everybody have a great rest of your day and great weekend. See you next time.